My name is Michael David, and I am an associate professor of infectious diseases and medicine at the University of Pennsylvania in Philadelphia in the United States. It's my pleasure this morning to welcome you to a webinar sponsored by the International Society for Antimicrobial Chemotherapy, or ISAC, and the European Sepsis Alliance. The title of the webinar is "The Pandemic Goes Away, the Real Pandemic is Here, Sepsis 2025. We have two excellent speakers today, and their talks will be followed by a question and answer session, which will be moderated by myself and by my co-chair, Dr. Sabiha Essack from the University of KwaZulu-Natal in South Africa. So it's my pleasure to welcome you today. Before we start, I'd like to share a little with you about the sponsoring organization, ISAC. The International Society of Antimicrobial Chemotherapy, or ISAC, was founded in 1961. It's a federation of more than 100 affiliated member societies worldwide. And the aim of ISAC is to increase knowledge of antimicrobial chemotherapy and to combat antibiotic resistance around the world. Every other year, ISAC hosts the ICC, the International Congress of Antimicrobial Chemotherapy, the next meeting of which will be December 7th to 9th, 2026 in Manila, in the Philippines. I welcome you to look at the ICC website for further details, and we would encourage you to attend. ISAC also sponsors two very successful international journals, the Journal of Antimicrobial Agents and the Journal of Global Antimicrobial Resistance. ISAC has a great number of working groups which power a lot of the work of ISAC, focusing on specialized areas related to antimicrobial chemotherapy and antimicrobial resistance, as listed here. As members of member societies of ISAC, individuals are welcome to join these working groups. The ISAC Academy is an online educational resource which hosts both ISAC and stakeholder educational material on key topics having to do with infectious diseases and antibiotics, including webinars such as this one. Again, I welcome you to visit our website to see what content is available. ISAC also sponsors the ABX, or Antibiotics Guide, which is an open access online antimicrobial treatment guideline for global application, which is intended to provide guidance on antibiotic treatment of common infectious diseases. It's written in an easy-to-use modular format that can be adapted to different settings. The main aim of the ABX Guide is to address gaps causing inappropriate antibiotic use in low-resource settings. ISAC also has society grants. These grants were developed based on a global survey on how societies function in clinical microbiology and infectious diseases. It was found that there's a clear wish for societies to be better equipped to make a bigger impact locally and regionally in the world. Therefore, ISAC offers grants for two purposes: one, to strengthen existing ISAC member societies, and two, to support new societies in a country that does not have one. The deadline for application for ISAC society grants is October 31st, 2025. Please see the website noted here for further details. ISAC merged with the Alliance for the Prudent Use of Antibiotics in 2019 after the retirement of its founder, Professor Stuart Levy. The APUA brings together many different aspects of antimicrobial resistance prevention and now features webinars such as this one, newsletters, produces publications, and also the development of antibiotic cards, which can be viewed on our combined website. Please follow ISAC on social media if you're interested in learning more about it and to keep up to date with new activities. So now I'd like to turn the program over to my co-chair, Dr. Sabiha Essack of the University of KwaZulu-Natal in South Africa, to introduce herself and our first speaker.
Thank you very much, Michael. So good morning, good afternoon, and good evening, everyone. As Michael mentioned, my name is Sabiha Essack. I hold a research chair in antimicrobial resistance and One Health at the University of KwaZulu-Natal in Durban, South Africa, where I'm also a professor in pharmaceutical sciences. Thank you for joining us for this important webinar on sepsis, a leading cause of mortality worldwide. The challenge is especially acute in low and middle income countries where delayed recognition, limited diagnostics, and constrained critical care services contribute to higher mortality, further compounded by AMR or antimicrobial resistance. This session is an important opportunity to share solutions and strengthen our collective response to save lives and build more resilient health systems. It is now my pleasure to introduce our first speaker. We are honored to welcome Dr. Ricard Ferrer, head of the Intensive Care Department at Vall d'Hebron Hospital in Barcelona, Spain. Dr. Ferrer graduated from the University of Barcelona Medical School in 1992 and completed his specialization in intensive care medicine between 1994 and 1998. He earned his Doctor of Philosophy from the Universitat Autònoma de Barcelona in 2010. Dr. Ferrer heads the Shock, Organic Dysfunction and Resuscitation Research Group, or SODIR, at the Vall d'Hebron Institute of Research and actively collaborates with several prominent research networks, including the Biomedical Research Networking Center in Respiratory Diseases, Education and Training in Sepsis, and the European Group on Infection and Sepsis. His scholarly contributions include numerous original and review articles in peer-reviewed journals, particularly in the fields of sepsis and severe infections, as well as several book chapters. His academic impact is reflected in a Google Scholar Age Index of 66 as of 2024. In addition to his research, Dr. Ferrer is deeply committed to education. He serves as an associate professor at the Universitat Autònoma de Barcelona and is co-director of the Severe Infections and Sepsis Masterclass at the European Society of Intensive Care Medicine. Dr. Ferrer, thank you for your participation, and I hand over to you.
Thank you for your kind invitation and also for this kind introduction. So for me, it's an honor to give this talk today, very close to World Sepsis Day, which is going to be on Saturday. So I'm going to start explaining the importance of sepsis because, as you know, what has been explained during the introduction, sepsis is killing more than 11 million people per year in the world, especially, of course, in these less developed countries. And it has been estimated, and probably it's underestimated, around 50 million cases of sepsis per year in the world. So it's an important disease with huge importance in terms of morbidity and mortality in the world. And we have several strategies for reducing these preventable deaths, including prevention, vaccination, monoclonal antibodies, infection control, early recognition and early starting of therapy. And here biomarkers, which is the topic of my talk, have a very important role in early recognition, as you will see during my presentation. Also, risk stratification is very important, and we have biomarkers for that. Improving the process of care, and sepsis fast track, sepsis codes play an important role. And last comment about precision medicine and also the use of biomarkers to provide personalized adjunctive therapy, I think, is very important. And also, I'm going to dedicate some minutes to artificial intelligence. So sepsis is a time-dependent disease, the same like myocardial infarction and stroke. Early appropriate antibiotics are associated to lower mortality, but of course the challenge is early identification of this patient and then treat this condition as a medical emergency, as is recognized in the Surviving Sepsis Campaign guidelines. And also the guidelines promote these type of bundles or early application of antibiotics and hemodynamic resuscitation fluids and vasopressors, together with microbiological diagnosis to reduce mortality with this early approach. However, in this survey that has been promoted by the the European and the Global Sepsis Alliance and other societies, we found that the implementation of early recognition in hospitals, this is mainly European hospitals, is still low. Also, sepsis bundles implementation also is low, especially in the wards. It's better in the emergency department and in the ICUs, but is worst implemented in the wards. Also, some concerns about laboratory diagnosis, microbiological departments providing 24/7 services is very limited in different European countries. And of course, this is impacting in time to results. And of course, this is very important for sepsis treatment and antimicrobial stewardship. So this is the situation, and we need to improve. And of course, we need to improve in this early recognition of sepsis. Early recognition requires identification of signs of infection. You know that sepsis is infection plus organ dysfunction, so we need to identify also organ dysfunction. Biomarkers may help, and microbiological documentation is very important. So infection detection, this is your clinical skills. You should be able to identify the most important source of infections that are related with sepsis, mainly pulmonary, abdominal UTI, but also, of course, catheters, neuro, skin and wounds are very important. SOFA score, it's mandatory to classify a patient with sepsis because the definition includes SOFA score of 2 or more for classifying a patient as a septic. But SOFA score is not useful for early identification. It's a delay classification of patient as septic, but it's not useful for early identification. So we have to use the biomarkers to increase this capacity of early identification of patients with sepsis, especially if we have biomarkers that can be enough sensitive and specific, rapid, and close validated, and with clinical validity demonstrated in studies, in clinical studies. So sepsis is an organ dysfunction caused by a dysregulated host response to infection, and this is the cascade of inflammatory phenomena and with activation of many cascades that happens in patients with sepsis. We have inflammation with inflammatory phenotypes, with anti-inflammatory phenotype, but also have this activation of the complement, this mitochondrial damage, this damage in the glycocalyx, this damage in endothelial cells, this increase in tissue permeability, and this immunothrombosis phenomena that also is affecting microcirculation. So it's a very complex disease, and it's a huge variability in these phenomena that are present in patients with sepsis. So we said that the patient have sepsis if they have a dysregulated response, which is described here. So it's very complex, and it's very difficult to classify a patient as dysregulated. We are using proteomics for hypothesis generating. So proteomics is useful in the sense that you use mass spectrometry to identify which proteins are overexpressed in the patients with sepsis or in the patients who are going to die from sepsis, and try to understand later which is the role in the process of sepsis, and they might be useful for sepsis identification. The list of potential biomarkers is huge. In these French studies, they evaluated a list of 29 biomarkers, and you can see that several of them have low performance in the left, and the better ones are in the right. And in this study, the best one was CRP, which is cheap and is really available in many centers. But when you look to the area under the curve of the best one, is around 0.75. So biomarkers in sepsis are not the holy grail. You don't have to rely only in the biomarkers. You have to rely in your evaluation of the patient, the signs and symptoms of infection, the organ dysfunction, together with biomarkers that may help you. You know that if you have an ideal biomarker, this ideal biomarker should rule in sepsis or infection. So if you have uncertainty, a good biomarker is able to say if it's positive that this patient has sepsis and you have to start treatment as soon as possible. But also good biomarker should be able, if it's negative, to say this is not sepsis, rule out sepsis, think in other diagnosis. But with an area under the curve around 0.75, in many situations, we keep in situation of uncertainty. So biomarkers in sepsis are not the holy grail, and it helps, but it's not just one value that you have to rely for saying this is sepsis or not sepsis. In this systematic review meta-analysis, they found an area under the curve for procalcitonin of 0.85 with a cutoff of 1 nanogram per milliliter for procalcitonin. Okay, this is better than the French study in this meta-analysis. So, but still it's 0.85. So that means that if your pretest probability that this is sepsis is 20%, if it's positive, so it's above 0.1, the post-test probability increased to 50. If it's negative, below 1.1, your post-test probability is 7%. So again, not the holy grail. We test these biomarkers in our emergency department in patients where we have the suspicion of sepsis. The best one for us was procalcitonin in identifying infection and sepsis, or positive blood culture in the right. But still, you see the areas under the curve. So based in that, you can build algorithm. We built this algorithm with Peter Sweats, trying to combine the levels of PCT with our certainty of infection. So combine our clinical evaluation together. So if this is the level of certainty we have together with the biomarker. And in most situations at the end, we said, okay, if you have certain level of certainty and the biomarker is above 0.25, in this case as a threshold, then we suggest to administer antibiotic. But if the level of certainty is low and also the biomarker is below the cutoff, then you can avoid giving antibiotics. But in patients that are very severe in the ICU, we increase the threshold to 0.5. And in most situations, we consider that if the patient is very sick, we have to give antibiotics and then de-escalate as soon as possible. Another concern with the biomarkers is that it should be adapted to many situations. One example is advanced age. So immunosenescence is affecting the immune response, and of course also it's affecting the levels of biomarkers. We are admitting those patients in the ICU, elderly and very elderly, which quite good results with sepsis. And again, in this population of very elderly patients, still the bundles are impacting. So the message here is that if you are able to identify sepsis early and you apply the sepsis bundle in very elderly patients, you're going to have good results. But you have to be very proactive and start the treatment very soon. And for that, biomarkers may help even before the patient has sepsis. But the biomarkers need to be adapted in this specific situation, like the elderly, and we have modified a little bit our algorithms with the same group of authors to include those patients with immunosenescence. Daily identification of biomarkers in patients in the ICU with other conditions, so confounding factors, so uncertainty, like polytrauma, could be also useful. Also in patients with viral infections, you know that bacterial co-infection is very important. Combination of CRP and PCT for us in a multivariate model identify patients with bacterial co-infection when they have COVID. So combination of biomarkers is something that I'm going to discuss also, because it may add value to combine several biomarkers, but combine value if there are biomarkers that they look to different of the systems that are activated in sepsis. So if you are looking biomarkers that are looking only for inflammation, maybe there is no value in combining, but if you are combining values of inflammation, coagulation, complement, etc., then probably they add value. And in this study, combination have higher area under the curve. But of course, increased cost is more time consuming and interpretation is sometimes difficult. Look, for this bioscore of 3 biomarkers, PCT, STREM, and CD64, the diagnostical ratio is 342. So really performing very well. So I guess combination of biomarker is a solution. Also, you know that we are using scores, and scores have limitations. In the last sepsis definition, they suggest QSOFA, but QSOFA have very low sensitivity, lower sensitivity than search criteria, and Muse score worse association with mortality. In fact, the guidelines are not recommending application of QSOFA, but QSOFA combined with PCT, there is an increase in sensitivity. So this is another potential strategy, or to combine QSOFA with ProEDM, again, an increase in sensitivity. So this is an interesting strategy. What about including this biomarker in the e-alerts? So the use of big data analysis, artificial intelligence for early detection of sepsis. So you see here the progression of these studies and how the studies are increasing the area under the curve when they use combination of data coming from the clinical information system. Again, in this meta-analysis, the prediction of sepsis using big data when it's 12 hours before sepsis in the right is difficult, but when the determination is close to the diagnosis of sepsis, the area under the curve is really high. However, when you analyze which variables have been included in these models, the use of biomarkers is low, and I think biomarkers introduced in these systems can improve. Not only they have a very nice area under the curve, there are some implementation studies showing improvement in process of care indicators, even improving in mortality. This is the one we have in Spain, which is an e-alert system working real life, evaluating all patients every 30 minutes and providing alerts. And it's working in several hospitals in Spain. It's on-premise, is a medical device, and is close to what we are saying. It's an artificial intelligent agent able to work alone, to work with autonomy and detecting sepsis in the hospitals. And probably in the future, we will see these agents, one agent dedicated for early detection of sepsis and other agents dedicated, for example, to antibiotic dosing. The Surviving Sepsis campaign is saying that this type of computerized algorithms probably are the future for early sepsis diagnosis, but I think it's very important that they include not only biomarkers, also rapid diagnostic tests. I'm going to dedicate the last minutes of my talks to talk about precision medicine and the diagnostic approach that we were promoting with Pedro Pobo and others in this editorial in intensive care medicine. The value nowadays of rapid diagnostic tests in microbiology, I think there is no discussion about that. It helps in many sense. Of course, they have some extra talks, but what about combining these rapid diagnostic tests that sometimes have difficulties in interpreting if this is colonization or this is infection, which is an important limitation of this technology, to combine this with the sepsis biomarkers. I think it's a very interesting approach, and we have several research projects in combining in a point-of-care device microbiologic detection together with biomarker measuring in the same point-of-care device. And with that, we think we can provide more informative data about if this is colonization or this is infection. And this is our process of care of sepsis in the hospital, and we have biomarkers helping us to take decision in different points, and we're happy to discuss about that during the Q&A session. I said at the beginning that patients with sepsis have a huge heterogeneity, and a huge heterogeneity means heterogeneity in response to different therapies. So this huge variability have made that many trials have failed. When we have heterogeneity in treatment effects, that means that there are some subgroup of patients that may benefit, but we are not detecting those patients because we have a lot of noise in the trial, because we are including patients where the effect is going to be neutral or patients where the drug is going to have produced harm. So we need to identify treatable traits in patients with sepsis that help us to provide the best therapy. And in sepsis, modulating the inflammation is really an important target if we were able to identify which patients really deserve this therapy. We have been working with the French group with the development of this non-gibotype, which is a small peptide that is an immunoregulator. The effects in terms of decreasing organ failure is increasing in this small phase 2 study, and we try to demonstrate better results in this phase 2b study that was published a couple of years ago, comparing non-gibotype in front of placebo in patients with sepsis. In the left, you have the whole population, but in the right, you have the population enriched by the biomarker. In this case, the biomarker is soluble DRAM above 400 picograms. And you can see that the change in SOFA score is significant for patients that receive non-gibotype when they have high levels of this biomarker. So that helps a lot to us to design the phase 3 trial that will start very soon, and patients will be selected by point of care measurement of soluble DRAM. So biomarkers also help in this approach of precise medicine, and I hope the results of this trial will be positive when we are combining a therapy that have a specific biomarker informing that this specific pathway is activated. The same example is for blood purification. Blood purification is not for every patient. We need to select the patients based in a specific biomarkers and then select the ideal device for purifying the blood of this patient. And the devices that are able to remove endotoxin are gaining attention in the recent years because we have the possibility of measuring this biomarker. In this case, is endotoxin activity. High levels are considered between 0.6 and 0.9. And in fact, in a post-hoc analysis of the EUPHATIS trial, they demonstrate benefit, but it's post-hoc, of patients that were selected based in the levels of this biomarker. So again, this is a diagnostic approach. The results of the TIGRES trial was specifically designed for treating patients with sepsis using the biomarker, this range of levels of endotoxin activity. The results have not been published right now, but during the last month, we heard a press release saying that it's an impressive reduction in mortality in the patients that receive this type of blood purification if they have endotoxic shock measured with this device. Also very interesting is stones as biomarkers, because stones is one of the PAMs. So stones are able to induce a sepsis phenotypes, and stones nowadays can be and are associated, in fact, can be used as a biomarker in several situations, correlate very well with PCT, CRP, and SOFA, can be measured. It's not easy. It's again, it's a mass spectrometry analysis. It's not easy, but again, it can help for selecting patients for blood purification techniques. Another specific subphenotype is the subphenotype of patients with sepsis and immunosuppressed phenotypes. This is very complex, just because sepsis patients can have an immunosuppressed phenotypes, but also there are many conditions like also aging, malnutrition, and many conditions that are associated with immunosuppression. Several biomarkers have been used for selecting this specific subphenotype of septic patients. recently also measuring inflammasome is demonstrated that could be an interesting biomarker for prognosis, but also for detect immunosuppressed population inside of the septic patients. Several immunostimulators have been tested in this setting, but right now still we don't have specific policy for using nivolumab or for using colony stimulating factors or other immunostimulators. Very interesting the role of immunoglobulins, especially if they are enriched with IgM. The example is trimodulin. We are doing the trial right now. This specific formulation of immunoglobulin is able to control infection and to control inflammation. We did this trial several years ago in Germany and Spain. We demonstrated again post-hoc some benefit in patients with high levels of CRP, low levels of IgM. And nowadays I am the PI for this ESCAPE trial, trying to study in a subpopulation of patients with severe community pneumonia, high levels of CRP, low levels of IgM, the benefit of using this formulation of immunoglobulin. So the approach for sepsis should be individualized therapy. I recommend this paper that we wrote in my group, trying to using biomarkers to identify different subphenotypes and try to provide as much as we can with the tools we have right now, personalized therapy for the most severe patients. So this biomarker guided management of sepsis may help to improve detection, early therapy, and precision medicine. So with that, thank you first to my hospital, to my team, and of course to you for your attention. And I will be happy to have questions. And also you are invited to Barcelona in a few days to learn more about sepsis. And of course, Professor Giamarellos will be also there. So thank you. You are invited to Barcelona very soon.
Thank you very much, Dr. Ferrer. It was very insightful. We've made some good notes. There are a number of questions in the Q&A that you're welcome to answer in writing, but we will pick them up at the end of the session as well, so both you and Evangelos can answer for them. Michael, over to you for the introduction for the next speaker, please.
Thank you very much, Sabiha. So it's my pleasure to introduce our second speaker for today, Dr. Evangelos Giamarellos, MD, PhD. He's a professor of internal medicine and infectious diseases at the Medical School of the National and Cappadocian University of Athens, and he's also the director of the MSc program of infectious diseases at the University of Athens. His main research contribution is immunomodulation in sepsis and in autoinflammatory disorders. He has 571 publications in international peer-reviewed journals, and he's contributed in the development of clarithromycin for immunomodulatory treatment of severe infections and in the recognition of hidradenitis suppurativa as an autoinflammatory disorder. He has been involved in the licensing of adalimumab for HS treatment. He's the current chair of the European Sepsis Alliance and the current president of the Hellenic Society of Chemotherapy. His main achievement is the approval of anakinra for COVID-19 pneumonia in adults by the European Medicines Agency and the Food and Drug Administration through the phase 2 and 3 SAVE and SAVE More trials, which he designed and conducted. So thank you very much, Dr. Giamarellos. I turn it over to you for your presentation.
Well, thank you so much, Mr. Chairman, for these elegant words and for your introduction. And today I would like to speak not just as a scientist who has devoted almost his entire career in the chasing of this, I would dare to call it monster, which sepsis is, but also I represent today the European Sepsis Alliance, which I have the honor and the responsibility to chair. Here's my conflict of interest for this disclosure, and I would like to briefly at the beginning of my talk to share also some information which has already been presented by Professor Ferrer. Actually, you already listened to the fact that there is a new sepsis definition. And this new sepsis definition takes into account a measure of organ dysfunction, which is coming from the SOFA score. And from the moment this new sepsis definition came into action, this happened in February 2016, exactly the next year, 2017. By using the sepsis definition, the question was, what is the year incidence of sepsis around the globe? And all of a sudden, we ended up that the number of patients are close to 50 million. And of these, 11 million, they die in 1 year. And these 11 million dying in 1 year are many, many more than those who have died during the entire pandemic. And the question then comes, how is it possible that everyone is speaking about the pandemic, but only few are speaking about the real pandemic, which is sepsis? Because from what I'm presenting you, we are in front of an endemicity, and previously you listened from the previous speaker that when the new steering committee of the European Sepsis Alliance came into action in 2019, our first idea was to see us, healthcare providers, how much are we aware about sepsis, either our general practitioners or also the public, also at the emergency ward and ward physicians and physicians in the ICU. In terms of the existing resources, the ability of early recognition, the guidelines of treatment, the diagnostic capabilities in terms of blood culture, for which you already listened from the previous speaker, and if indeed there is somewhere in this globe quality control in hospitals for these actions. In order to do so, we shared these questionnaires as members of the European Sepsis Care Steering Committee, in collaboration with many international societies, asking healthcare providers to give their feedback. And as a matter of fact, you know that there is the impression that this may vary from one hospital to the others, and probably it could be that Western societies or Northern societies, they perform better compared to the rest of the world. So we had a worldwide distribution, and here is the first question. How many hospitals they provide screening for sepsis per geographical distribution? And the gold standard is what you see, the green line, the dashed line. And you see that everywhere in the world, irrespective if you're an intensivist, an emergency care physician, or an internist in the ward, irrespective where you stay or where you act, there is down performance, poor performance. And if the question switches into, do we provide sepsis management according to Surviving Sepsis Campaign guidelines? Again, all of us were poor performers. And if you switch about, is there quality control of that in the hospitals? Again, the same answer. And our teachings was that there is no standardized teaching, no SOP for management of sepsis, no training, or there is, but not at the level we would wish that to be, and which means that we need to implement specific measures and structures, which will offer as a principle the training of healthcare practitioners, and also audit that what needs to be done is done in the correct order. So my topic was holistic management. And exactly these teachings from that European Sepsis Care Survey introduce the concept, what needs to change? Actually, so far, all of us, we believe that there is one action which can save a patient. That the antibiotic reaches the blood circulation of the patient early. How early? Here are data which were published already 20 years ago, and which they show that if the antibiotic, the correct antibiotic, manage to get access to the bloodstream of a patient the very first hour from start of hypotension, the likelihood that the patient dies after 28 days is 20%. What you see here, this 80%, is the overall survival. And look how the survival goes down by a relative 7.6% for every hour of delay. So actually what we need to do is pretty simple. Where do we fail? First of all, we fail to the recognition of sepsis. In other terms, we need to teach our healthcare providers who's the patient, and the other which fails is the correct antibiotic, because correct antibiotic is a daily therapeutic challenge, which means that we identify if the patient which we have in front of us is infected by a susceptible pathogen or a multi-drug resistant pathogen, and we need to start empirical treatment guided by the likelihood of risk and reconsider that we up-escalate or down-escalate in case the pathogen is isolated and there is antibiogram for guidance. In other terms, what needs to be done? How can we improve ourselves? How we can deliver the appropriate treatment, and how we deliver the empirical treatment. So the first question, what is the likelihood that I have in front of me a patient infected by a pathogen which is producing extended spectrum beta-lactamases and hydrolyzes beta-lactams? So we need immediately to learn from the past history of the patient if he or she was hospitalized the last 3 months, if he was administered broad-spectrum antibiotic the last 3 months, if he's undergoing chronic hemodialysis, if he's a resident in long-term care facilities, if he suffers from recurrent urinary tract infections, or he's bringing catheters, either IV catheters or urinary, or there is known colonization by ESBL-producing pathogen. And the other endemicity which we have is that we have not just in our hospital, but also nowadays in our society outside the hospital, pathogens which are resistant to carbapenems. And the risk pathogen are known colonization or known recent infection by these pathogens, or recent ICU colonization, or severe immunosuppression. And according to our Greek guidelines, what we do in our country, where there is prevalence of multi-drug resistance, if these risk factors are absent, then we start our patient empirical with a third-generation cephalosporin. We add a macrolide in case of community-acquired pneumonia, or metronidazole in case of intra-abdominal infections. But if there are no risk factor and the patient was recently exposed to third-generation cephalosporins, we suggest empirical treatment with piptazole. If the risk factors are there, empirical treatment with carbapenems or ceftolozane-tazobactam, and if, of course, the risk factors for infection by carbapenemase producing gram-negatives, then we want one of the recent antibiotics, which they hydrolyze carbapenemases. And if a patient is more severe, and more severe means a SOFA score 8 or more, and the patient is presenting septic, but outside the ICU, then the algorithm is more or less the same, with just the exception that we are more attacking the infection in much more broader spectrum antibiotics earlier. But as a matter of fact, one of the problems which we have with antibiotics is that there are too few of the existing trials out there which they have mortality as their primary endpoint. Probably the most impressive one is the AIDA randomized controlled trial, which was published in the Lancet Infectious Diseases. And I'm really happy that Professor George Dikos was in the steering committee of the trial, an open label randomized trial with patients with sepsis infected by carbapenem-resistant pathogens, and they were split into treatment with colistin monotherapy or a combination of colistin with meropenem. What was impressive there is that, first of all, we learned that the overall 28 mortality by these pathogens is around 40%. but also that the addition of meropenem does not bring anything more than side effects to the patient. But when you need to prescribe colistin, I kindly ask you, colistin is not like the other antibiotics. You should not prescribe to all patients the same dose. And even if the patients, they have what we consider in a very conservative approach in our daily practice, that they are at normal renal function, please remember this table. For every change of 10 ml per minute of the clearance of creatinine, you need to adjust the dose of colistin, even if this 10 ml per minute change brings the patient within a window that we traditionally consider normal renal function or mild or moderate renal dysfunction. And I would like to finish my talk with a publication coming from our Greek infectious diseases collaborators, showing that in patients with pneumonia, and why pneumonia? Because pneumonia is the main driver of sepsis, is the main driver of death. It was over the years, and it still remains with the years. There is a specific phenotype, which if you recognize early and you treat early, indeed you save lives. So, which is the phenotype? Patients, adults, with at least 2 signs of the systemic inflammatory response syndrome, with a total SOFA score 2 or more, with procalcitonin more of 0.25, with at least 2 of cough, purulent sputum, dyspnea, pleuritic chest pain, of course, with a new shadow in chest X-ray. And these, they are randomized to 7-day treatment with standard of care antibiotics and placebo, or standard of care antibiotics plus clarithromycin, 500 milligrams twice daily for 7 days. Which is the primary endpoint? Composite endpoint require an early response, the first 72 hours. The response the FDA wants to get, at least 50% decrease of the respiratory severity symptom score, but here we made that far more difficult. On top of this, we want that our patient experiences decrease of the SOFA score or an improvement of procalcitonin. Look at our patients. They are the modern elderly, meaning of our ages, meaning 75 years and more. They have severe comorbidities. They have pleural effusion at a level of 30%. All of them are hypoxemic. They have a pneumonia severity score around 120, making them suffering from severe pneumonia. Their CRP is more than 150, and the standard of care medication they received was either a 3rd-generation cephalosporin or beta-lactamase inhibitor or piperacillin tazobactam, and many of them received on top corticosteroids. So the primary endpoint, early response in terms of symptoms plus early decrease of SOFA score or early decrease of procalcitonin. And this is achieved in almost 70% of patients receiving clarithromycin, compared to 38% of patients receiving placebo, and the difference is huge. The odds ratio is 3.4, but someone will say, okay, symptoms are resolved early. Now what we want to see is the critical component, the sepsis component of our patients. So which is the biggest fear of community-acquired pneumonia? That the patient deteriorates, he's in need of mechanical ventilation, and he's intubated and brought in the ICU. And this indeed happened in 17.3% of patients treated with placebo, compared to only 6% of patients treated with clarithromycin. Then, all of a sudden, someone brings in his mind the ages when he was a young fellow. And when he was coming to hospital, he was thinking that he could that day discharge some of his patients. He was very happy about that. And as he was coming to hospital, the fellows which were on service the previous day, they tell him, oh, unfortunately, you cannot discharge him anymore because he's septic again. And sepsis, new sepsis could be either coming from the lung or a new sepsis foci, and this can be prevented with clarithromycin treatment. The incidence of secondary sepsis was 24.1% in the placebo arm compared to 13.4% in the clari arm, meaning a relative risk reduction of 48%. And then the question comes, resolution, no risk of mechanical ventilation, no risk of secondary sepsis. What does that mean? Earlier, go home alive and hospital discharged. With that, I would like that we keep to ourselves that there are two secrets for sepsis management. The first is if indeed the patient is heavily septic, early antibiotics. If not, but what we face is community-acquired pneumonia. If this community-acquired pneumonia has signs of systemic inflammation, SOFA score 2 or more, procalcitonin more than 25, then if this patient requires hospitalization, he should receive clarithromycin, but also if he has severe comorbidities, then this is the profile of treatment of our patient with clarithromycin. With this, I would like to stop. I would like that all of us, we keep in mind that every year, the 13th of September, is the day where the world recalls all these people who every 3 seconds they die because of this modern pandemia, and for which all together, united, we need to join our forces to improve their outcome. Thank you very much, and I'm looking forward to the discussion.
Thank you very much, Dr. Giamarellos and Dr. Ferrer, for your fascinating and thorough presentations on sepsis. I think that they raised a lot of questions, and hopefully it's been very interesting to our audience. So I'm going to take questions from the audience from our Q&A chat. And again, I encourage you to put your questions there if you have them. So the first question, perhaps for both of you, and maybe we can go in order of your speaking, Dr. Ferrer first. A question from the audience is, LPS is a major trigger for septic shock. What measures are taken to ensure that antibiotics used to treat patients do not promote the release of LPS from gram-negative pathogens?
That's a very good question because of course killing of gram-negative bacteria produce a release of endotoxin. I have to remind you that endotoxin, when you are measuring endotoxin in sepsis, we are measuring endotoxin that probably come from gram-negative bacteria that are causing the infection, but also in patients with sepsis is coming from translocation from the gut. Okay, especially in patients that are in septic shock, they have low perfusion in the gut. This produces also translocation coming from the gut. But of course, killing gram-negative bacteria produce a huge amounts of endotoxin. Cephalosporins produce more liberation of endotoxin than carbapenems, for example. So we have to know that. But also combining those antibiotics with clindamycin, for example, that blocks protein production, can help also to reduce the amount of, so pre-treat the patients first with clindamycin and then use the beta-lactam, protects the theoretically, but I mean, it makes sense that can protect endotoxin liberation. So that's a potential strategy, and in fact is used in some infection like soft tissue infections, etc.
Dr. Giamarellos, do you have any comments?
Well, I don't believe that there is anything more to add. I mean, that was really perfect what Ricard said. So no add on my end.
So the next question that I'm going to focus on has a LMIC perspective. And the question is, what biomarker will you suggest for the LMIC to diagnose sepsis? Because blood cultures come late and often do not yield pathogens. So in a LMIC context, what would you suggest? Who would like to go first?
No, I mean, you have seen some of the results comparing several biomarkers, and really CRP is not performing worse than other which are more expensive. So I think CRP is more available, its cost is lower. I think that can be the right biomarker for those settings. But again, don't rely only in the biomarker. Combine these biomarkers with your clinical knowledge and your clinical evaluation, because it's going to help, but just help. You need your clinical evaluation, of course, for saying if this is sepsis or not.
Well, if I may add on the discussion and fully add on what Ricard just said, I remember when I was young, I asked my mentor, "Can you tell me in real life, what is the definition of sepsis?" And I got a reply, "I don't know the definition. I know to recognize that by looking at the eyes of my patient." So the clinical feeling comes first, even if you don't have all the signs, but you have the feeling. This is where sepsis is. And always, I believe that we need to bear in mind, be afraid of pneumonia. When I was younger, I was pretty enthusiastic with urinary tract infections because they're impressive. They have a lot of fever. They have a lot of neutrophils. They have high CRP. But then I realized that if you give early one shot of antibiotics, it's done. Pneumonia is a tricky and fearsome business. And I assume, Ricard, you agree on this.
Yeah, fully agree. And of course, the population that we are facing in other countries, especially Greece and Spain, where we have a very old population with this immunosenescence profile with a lot of comorbidities. And in fact, many of them have kidney transplants, many medications that are modulating the immune system. Recognition of these infections, not only pneumonia, also UTI, is really, really a challenge. So really, we have to pay a lot of attention in these patients. And despite some of these patients, we think, okay, this is an old patient, this is a patient with a lot of comorbidities. Probably is not a patient, I mean, for the highest level of therapy, for an ECMO run, for example. But those patients, if we don't treat those patients very early, since we recognize that this is a bad infection, for sure that they are going to die. So we have to be very proactive in those frail patients to early recognition, and provide early therapy. Frail patients, I mean all patients, patients with comorbidities, patients receiving any therapy that is modulating the inflammation, because those are great confounders.
Great, thank you very much. The next question is, what is the role for teicoplanin and vancomycin for empiric therapy for sepsis? And if you can just comment briefly on that. I think neither of you spoke much about those drugs.
Ricard, may I go first?
Yes, of course.
Well, thank you for this. As a matter of fact, I did not speak a lot because of the sake of time. I want to make clear that if a patient, first of all, when I presented about our suggestions and our guidelines for empirical treatment, I focused on SOFA 8 or 7 as a cutoff. It depends on how you see it, of severity. And if you ask me why 8, I'm telling you it's very easy. If you are an 8, you have ARDS and also you are dependent on vasopressors. So the outcome of the risk of mortality is the patients who are 8s and more, by definition, they need to get a glycopeptide. If you ask me which glycopeptide, if the patient is on community-acquired pneumonia, I would go for linezolid. If the patient is not on pneumonia, I will go for vanco and not teco. Why not teco? Because the PK of teco, after 30 years, teicoplanin is in the market, yet are not really discounted. And for us clinicians, vanco remains an easier to handle antibiotic. But Ricard, how do you feel about this?
No, of course, fully agree with you, Evangelos, and maybe also add which is the risk of having MRSA in your community, because of course, if the patient has risk factors for, is a patient who have contact with the healthcare system, the risk of MRSA is higher. But for those that don't have contact with the healthcare system and they stay in the community, or also in Spain, we have a huge problem with long-term facilities, which is the risk. And of course, if the patient is sick, really sick, in organ dysfunction, and you have certain risk in the community, I'm also in favor of giving this type of drugs in patients with community-acquired pneumonia, which is not in the protocol. It's not in the protocol, but will depend in the risk factors for MRSA and how sick the patient is.
Thank you very much. We have a question around viral etiology of sepsis. So how do respiratory viruses impact sepsis? Are we seeing more viral sepsis, or are the diagnostics just revealing its true prevalence now?
Well, the capacity for diagnosing virus has increased a lot, especially after the COVID pandemic. So now most of the patients coming to the hospital, they just have screening for influenza and COVID, and if the patient is admitted in the ICU, have BAL and multiplex analysis for different respiratory virus. So the capacity has increased a lot. I think multiplex capacity is available in many hospitals. So have more and more diagnosis. Saying that this viral infection is sepsis, okay, if they have organ dysfunction, I'm in favor for saying that this viral infection, especially if the patient have viral pneumonia, this is sepsis. But not only for that have increased the incidence of sepsis, is because viral infections have bacterial co-infection, or it's the trigger of a secondary bacterial infection, which in many cases go with sepsis. So I think viruses are playing a very important role.
Evangelos, would you like to add to that?
Actually, I fully agree on that. And we need to take into consideration that exactly because we have this new technology, what we learned over the years, and this has started already with the famous publication in the New England almost 10 years ago, showing that most of community-acquired pneumonia is a co-infection, where one of the pathogens is a virus and the other pathogen is bacteria. So I'm pretty aligned with what Professor Ferrer just said.
Excellent. I think we have time for maybe 2 more questions, and then we can give a very brief summary. Since we started a little after the hour, I think we can use an entire hour for our webinar. Someone did ask a question that I can answer, which is the webinar available afterwards for viewing in the future? And yes, it is. Our webinars are archived and available free of charge indefinitely on the web from our website. So we have another question that's quite interesting, and I think we haven't addressed yet. Would you, the speakers, suggest that sepsis screening in the outpatient clinic should be different from that for inpatients or in the emergency department? As most outpatients with sepsis present with more mild conditions, it's easily underestimated and may later progress at home. Do you have any comments for people about surveillance or identification of sepsis in the outpatient setting?
I am intensivist, Evangelos. Maybe you're more close to the outpatient world.
Okay, so exactly, this is actually, Ricard actually said what we speak about. The screening is completely different outside and inside the ICU. And actually, Ricard already elaborated on the point of QSOFA. But one of the elements of QSOFA has to do with respiration. So how can you, and also of confusion. So how can you evaluate confusion and respiration in a patient who's already under mechanical ventilation and sedation? With that in mind, when we are at an outpatient setting, if we want to give, let's say, a horizontal approach, we can say that there is one extremely triggering point, which if you look at it, sepsis is your first suspicion, and this is acute confusion, irrespective if the other elements of QSOFA are not there. And of course, QSOFA is really a nice guidance, but if two or even all elements are there, everybody is happy. If there is only one, it does not mean that sepsis is excluded. And what I would suggest, Ricard, that for our audience, that we just repeat the three elements, which are systolic, less than 100 millimeter mercury, more than 22 breaths per minute, and confusion.
Yes,
Thank you very much. Please go ahead.
Great comments, Evangelos. I just want to mention that we try, so we have a sepsis code in our region, and we try to identify patients as soon as possible, even before coming to the hospital. And it's really, really difficult. I mean, we have to try to generate something similar to stroke and myocardial infarction, so the patient can alert that patient has symptoms that may be sepsis, or primary care can alert that this patient may have sepsis, and it's really difficult. There is not something like chest pain or something that really can alert in the outpatient. And if we take, confusion, fever, etc., probably we are going to generate a lot of false positive alerts that is going to collapse the system. So in the outpatient setting, really is challenging to try to do early identification, transfer to the hospital, start the therapy. This is really, really challenging.
Thank you very much. And maybe the final question around antimicrobial resistance and sepsis. So resistant infections often delay effective therapy in sepsis, worsening the survival rate. And what are your thoughts about balancing urgent empiric antibiotic use with antimicrobial stewardship? Evangelos, perhaps you can go first.
So the current approach is that you use the existing risk factors for infection by any of these resistant pathogens, which they guide you exactly what to choose. But what is very important, and I believe Ricard will agree on that, the new technologies, particularly the film RA or the multiplex PCR in the blood, which can detect resistant genes, can in the very first hour allow an early switch in case the empirical administered treatment fails to cover the resistant bag.
Yes, I mean, sepsis team should be tightly connected to the teams that are doing antimicrobial stewardship, because we have to promote early broad spectrum antibiotic when you are in empiric phase. But as Evangelos was saying, you are reducing time to diagnosis. We are reducing time to diagnosis with the new technologies, but we need that the antimicrobial stewardship team or the expert is also very close to the patient, because the decision to de-escalate or to stop antibiotics, whatever, should be taken also as soon as possible. So it doesn't make sense that the lab is going fast and expending money in expensive tests if we are not de-escalating also very, very fast. So both strategies, early antibiotics in sepsis and antimicrobial stewardship, should work together in providing the optimal therapy.
So thank you very much for your responses. Now I think Dr. Essack will give a brief summary, just a couple of minutes of the main points that were made in the webinar, and then we'll close the webinar.
First of all, to say thank you very, very much to both the speakers. This was an exceptionally good learning experience for me, who's a pharmacist and not in the clinical environment, but I can understand. And thank you for simplifying the very complex topics to make it understandable for the wider healthcare professionals. So, Dr. Ferrer, you started off by speaking about statistics, more than 50 million cases and 11 million deaths. And you spoke about the importance of how sepsis presents, how important early recognition is, and you went on to speak about the precision medicine. So you emphasize that early recognition of sepsis is key, and you focus on the different types of biomarkers that can be used singly and in combination to give us this diagnosis. And we spoke specifically about CRP and PCT, procalcitonin, and which are the known ones, but also histones, which are emerging as biomarkers as well. We also spoke about the rapid diagnostic tests with the together with sepsis biomarkers as point of care testing, which makes it very which should be used more if we want to get into early diagnosis. The heterogeneity in treatment effects is also something to be considered, and therefore treatment has to be individualized, making a role for precision medicine. Professor Giamarellos, you emphasized the importance of early recognition, and you sort of highlighted the underpreparedness of most countries in managing sepsis. You gave us a very good overview on evidence-based treatment options based on patient demographics and characteristics, clinical signs and symptoms, as well as risk factors, especially when it came to risk factors of being of the positive organism being multi-drug resistance. And you highlighted the success of clarithromycin for sepsis when sepsis was related to community-acquired pneumonia in patients, especially those that had particular risk factors such as morbidities and mortalities. I hope I've managed to capture the wealth of information that you shared in this short time, and I hand over to Michael to make the last comments and close the webinar. Thank you very much.
Thank you very much, Sabiha. And so I just want to briefly say, again, thank both of our excellent speakers, really world leaders in research on sepsis. I think we all have been convinced that this is still a pandemic that's ongoing, that's under-recognized. We have a long way to go, both in early diagnosis and therapy for this terrible infectious diseases syndrome. And so I thank you all for attending today. And I want to just remind you that this webinar was sponsored by the International Society for Antimicrobial Chemotherapy and the European Sepsis Alliance. Please look out for notifications for future webinars from ISAC. Please do check out our presence on social media platforms, which are noted in the chat. And you can look at our website, the ISAC website, for future events as well. So thank you very much for attending, and we look forward to seeing you at our future events. Everyone have a good day.
Thank you. Bye.
Thank you. Bye-bye.